I'd like to welcome our next panel onto the stage. And while they are coming up, I'll introduce you to our moderator, Eric Taub, who is a journalist for the New York Times and has been writing about the intersection of technology in consumer lives as well as healthcare. And so he's a perfect person to lead this discussion. Thank you.
Thanks, Jill. And I also, like Jill, know the implications of working with people who have Alzheimer's and or mental illnesses. I've seen a good friend of mine be totally devastated by his 50-year-old wife who has end-stage Alzheimer's. I've seen it in my own family. Many of us have taken care of family members, and we know not only is it difficult for them, but how difficult it is for those of us who are taking care of people. And there are the Alzheimer's Association has some interesting facts. First, just speaking about the perhaps basic financial issues around Alzheimer's. It's going to cost Alzheimer's disease and all dementias in the US currently cost $259 billion, and they expect that to quadruple in the next 35 years. And 2/3 of the people who are caregivers of people with Alzheimer's are women. And 34% of those are over 65. And one thing I found really interesting is that 35% of the caregivers say their health has gotten worse by taking care of people, compared to 19% of the general population. And similar with regard to mental illness, those people who have mental illnesses, according to the National Alliance on Mental Illness, die 25 years sooner than the general population. So we've got a big problem, and it's going to be a growing problem, of course, as the size of the older population ages. And we have three people here who are looking not to cure Alzheimer's, but to mitigate its effects, to improve people's lives, outcomes, and improve the lives of people who care for them by doing a more integrated, intelligent approach to caregiving. And sitting right to my left, your right, is Jay Patel, who's the Clinical Transformation Officer for Senior Link, and started his professional career as a pharmacist. And one thing that Senior Link they've come out with some studies, and some of the work that Jay and his colleagues have been doing have decreased dementia patient hospitalizations by 71%, emergency room visits by 50%, and the number of falls, which we all know are usually precursors to much more serious incidents, by 17%. Tell us how you're doing this.
Yeah, absolutely. So let me start off by giving you a little bit more context. So Senior Link is a Boston-based care collaboration solution. So we are focused primarily on the value of a caregiver, and we are focused on getting that caregiver to be engaged as an active part of the care team. We do this through supporting and coaching and engaging those caregivers in order to activate them to make sure that they are a vital part of the care team curriculum. And so essentially, it's great to have best practices and outcomes-based approaches, but those often fall down when you don't have the right folks executing in that care. And so the statistics that you mentioned, Eric, are related to a pilot that we did. And so when you think about caregivers, we tackled dementia to be one of our signature programs. And we did that for two reasons. One is, clearly the demographics that you mentioned, right? It's a $250 billion disease that's going to go up to $1 trillion in the next 30 plus years. And that's primarily driven by the demographics, right? There's just so many more people that are going to be aging. And you think about the boomers, that trend supports that. The other piece of this, though, is that there's always a caregiver. Typically when you're trying to make an impact on dementia care and Alzheimer's management, you need an active caregiver to be involved. And you mentioned some statistics there that, of those caregivers, 2/3 of them are women, and some of them are of older age. But the other thing that's relevant here is that they are often the ones that are the most stressed. You think about caregiving itself is a burdensome process and to be involved for someone or caring for someone who's a dementia patient is even greater. There was a JAMA study that came out recently around the amount of days that you provide care for. On average is about 66 days per month, or 66 hours per month. Sorry. And for regular caregivers, for a caregiver of dementia patients, it's up to 170 hours. So the demand is high. So that's why we tackled that condition first. And what you saw is essentially, in those results that you mentioned, a training program, an educational protocol that we put into place where we had social workers and nurses involved using technology on a daily basis in order to engage caregivers and to understand when they needed support, to provide them with some of the coaching to help them tackle things like foundational components about what dementia is, how to communicate with the person they care for, and then how to identify challenging behaviors. And so when we did that program and we measured a pre-post utilization analysis on hospitalizations, falls, and ER visits, we saw the results that you mentioned.
So you say use technology. Could you be more specific? What technologies are they using?
Yeah, so we have a homegrown technology platform called Senior Touch today that's in place in our intensive care collaboration model. So when we're going into the home to make home visits, we use Senior Touch on a daily basis to engage with caregivers. As we move forward, we've built Vela, which is another care collaboration platform that's HIPAA secure and intended to engage caregivers daily and ad hoc whenever they need them. And so finding this balance, and I know Rena's going to talk a little bit about this balance around human touch, actually calling people and getting into the homes and visiting them versus technology when you can't be in the home and you can't be on the phone with them. Having that balance and understanding when's the most appropriate time for a caregiver to engage and when they need help is what we've been able to leverage.
So in essence, you're dealing with a population of caregivers who may not be the most knowledgeable about how to give care to the people they're working with. So you're intervening, working with them on a regular basis, educating them, and then following up to make sure that they haven't lost the skills that you're instilling in them.
Absolutely. And the other thing that's important in this, Eric, is especially with Alzheimer's patients and their caregivers, it's less about, clearly there's a need to educate and coach on a training, so to speak, but a lot of this is about support. A lot of it is just knowing that I've got somebody to talk to and I can call someone or text someone and engage with them and get the feedback I need in order to keep me A, motivated, and B, make me feel confident and assured. And that's a critical component of the model that we have that balances that human touch with technology.
Staying engaged with those people is interesting, and I know that Dr. Rena Pandey, who's the Chief Medical Officer for Able To, is involved in work around mental illness, and you are a cardiologist. I don't think in the past tense you are. But you've also done a cardiac study, haven't you? And because there's also a lot of mental issues around people who have heart disease.
Yeah, no, exactly right, Eric. So yes, I am a cardiologist, although I do little clinical
You don't
work
retire
these days.
from it.
My kids give me a hard time. They keep telling me I'm not a doctor anymore. I try to fight that. Okay. But what drove me from academic cardiology over to my work at Able To was this appreciation, similar to what you're saying, Jay, that for so many people, we focus on their physical health, and yet there are all these other factors, their lifestyle, behavioral health, underneath which oftentimes is a mental health component that we, frankly, as a healthcare system, don't sufficiently address. And I kind of went, wow, there's got to be a better way to do that. There's got to be a way to take technology and use technology to enable getting very high quality and evidence-based mental health care to these folks. I mean, in cardiac disease, 1 out of every 4 patients leaving the hospital after a heart attack has major clinical depression. We find and treat a small minority of those patients. So in our work at Able To, we're getting high quality behavioral health care remotely delivered through phone or video enabled by our technology platform to patients like that in their home so that they can get access to the kind of care they need. And what we found, similar to the work you guys had done, Jay, is that if you can get patients the kind of care they need in the right way at the right time using technology, boy, can you reduce all the bad outcomes that we were seeing previously, right? So fewer hospitalizations in that very early period after they'd been admitted for a cardiac event, fewer days spent in the hospital and other disease conditions, we've found that by tackling the mental health component of overall health, you can keep people out of the hospital, you can improve their work productivity, less missed days at work, more productive when you are at work, so on and so forth.
Right, because all these things have these snowballing effects. So if you have clinical depression, then you're not going to go to work, and then you miss days, and
You got
it
it.
hurts the place you work at as well.
I call it a kind of core or foundational comorbidity. I mean, it's everywhere, and we just don't address it sufficiently. So to the big health issues that we could tackle, I mean, if we could pay attention to mental health in the same way we pay attention to heart disease and diabetes and high blood pressure, the impact that we could have across multiple outcomes, across the healthcare ecosystem, frankly, across life outcomes like working and living and being productive, could be massively impactful.
And then even speaking on sort of a crude basis, I mean, being able to keep costs down also is very important. And Dr. Amy Kahn, you're involved with an insurer, and the two of you are working together, aren't you?
We are,
as
yes.
companies.
Right.
Yeah. What are you doing together?
Okay, so within that, and first of all, I did want to, by the way, thank you, Jill, for including me on the panel today. I felt like it was important to have a perspective from the insurer side. I also need to disclose that I am under the influence of over-the-counter cough medicine and cold medicine, and my ears haven't quite cleared from that descent. So if I sound like I'm echoing as I speak to you. At any rate, having said that, I'm really excited about the collaboration we have with Able To and working with Rena and her colleagues, in that it is an intensive clinical cognitive behavioral therapy intervention that is time limited, 8-week program that couples a licensed therapist with a coach, twice-a-week visits, if you will, kind of intensive kind of a setup, and engages those individuals through either televideo or telephonic access. Incredible in that it allows people to get into, if you will, and see and hear a therapist should they want to, but then in addition to the therapist and helping to identify some of those emotional challenges that they might be dealing with as they relate to other comorbidities, whether it be they have heart disease and they have depression, or they have diabetes and they have anxiety, or they have postpartum depression, they're struggling with chronic pain, they have any number of issues going on. We know there's an emotional component that isn't necessarily being addressed by their clinician, nor is there an opportunity for it in many parts of our country for them to get in to be seen in a timely manner. So through the Able To collaboration, the network that's managed by Able To allows our members to basically access the coach and a therapist and get the sort of support that they need to be able to make their life work, support them, if you will. One other comment I want to make is that I came into this field as an internist, although very quickly, early on, I specialized in the field of addiction medicine, and in part was because every patient I saw in my primary care practice had a whole lot of other things going on that we didn't really address. So very much in the same way you moved from cardiology to this space, I think I recognized very early on that our behaviors, our emotions, our social environments, our communities had so much more to do with how we were doing medically. And as we think about our social determinants of health, and I think the previous speaker sort of alluded to that in one of his graphics, we have to talk about what is your community. We need to talk about things like our behaviors and how can we make choices for better behaviors. And maybe we know what to do, but frankly, we don't have the resources to do it. Maybe there's transportation challenges, maybe there's a homelessness problem, other issues that we're all facing. And so at the Aetna system, we take care management to that level of really understanding the whole person and include both synchronizing the care management plan for an individual, because quite frankly, our systems are very provider-centric, and they're not really people-centric or patient-centric or person-focused. And so we want to make sure that that care plan makes sense to that individual. It's what they want, they understand it, and then we make sure that's synchronized with whatever their treating providers have outlined. But then going that additional, that additional mile by engaging that individual, including their family members, their other significant others, their other dynamics that they may need to attend to. For example, many of our members in national accounts are the employee for a plan sponsor. So we want to make sure that's working for their work situation. Are they able to do their job? And we really do tackle the dimensions that include things like work productivity and presenteeism and impact absenteeism by allowing people to sort of recover in their own lives I've joked in the past that we all need a 12-step program, right? The fact is that all of us need a blueprint to be able to address those physical, emotional, social, and frankly spiritual aspects of our lives in order to have a successful outcome. Not just not being sick. I think that's just shooting too low in terms of what health is. It's really about what is our potential? Can we create and reach our potential in terms of our health aspirations, our economic aspirations, our goals?
So this model that all of you are working on is not a new one. When I was in my 20s, I worked in the notorious Rikers Island in New York, doing exactly this sort of work. We were engaged with prisoners who were about to be released and worked with their families and their employers to get them back into society.
Yeah.
And it was a massive failure, this project. It was started by legislation from Robert Kennedy before he was murdered. And after he died, they then instituted it. What are the challenges to make this viable? I mean, it's not a simple process. You've got to vet the people you're working with. You've got to have continual contact with the end users in a sense to make sure they don't fall back. Talk about, please, all the problems or challenges, I should say, that you're working with.
So
We would probably speak all day about
I
the
know, yeah.
challenges,
So
and they're probably unique to the different things we do. So go ahead.
Well, so I'll just
chime
start,
in.
and I think there may be some overlap. Clearly, I mean, I think that the first thing that raises the red flag that we always worry about within our organization is just engagement in terms of the caregiver and the consumer. And so, and especially when you speak about Alzheimer's and mental illness, the consumer doesn't always have the most clear voice, and so the consumer patient, and so you have to rely on family members to help. And these people are already busy, right? I mean, they're not just sitting around looking to hop onto an app and engage with you just because you send them a set of surveys, just because you send them a video, as well-intentioned as it seems and as appropriate as it may be, doesn't mean that it's going to get the value that you hoped for it to get. So I would say, kind of piggybacking on what Amy had talked about being what I will frame as being person-centered. I think having that relationship, building that trust with folks, and again, you can't do it over an app or through technology solely. You need some contact. Building that trust helps give you an avenue on how we at least approach the challenge of engagement and getting people to communicate with us more regularly.
Yeah, engagement we share as a challenge for sure. I think of it in a couple of ways. One is you have to be able to find people in need, number one. And in mental health care, that's proven time and time again to be a challenge, right? Half of the people who have emotional challenges and mental health issues are not diagnosed and are not being treated. So number one is, how do we find them? So we, in our partnership with Aetna and with other partners, we actually get a ton of data. We're sifting through that data. We're applying our clinical algorithms, and we're trying to find clues that tell us that you might be at risk of having a mental health condition that's either been found but inadequately treated or hasn't yet been diagnosed. So finding people is number one. Engaging them successfully. In mental health care, there is still a big burden of stigma. And so we still have to overcome not just, hey, you have this, but B, it's okay to not be okay. And it's okay to need and ask for help. And then beyond that, the challenge of getting the treatment to folks, right? And getting high quality treatment. So it's one thing to have a platform that connects a clinician and a patient. It's great. It's a massive advance forward. It lets care get to patients in rural settings and other places they might not have access to it. But one notch up from that is having that care be extremely high quality and evidence-based. In mental health care, that happens not nearly enough. So we've put a lot of effort and energy around structure, protocols, evidence-based. And I like to joke that the care is not rocket science. I mean, there's decades and decades and decades of research that shows that this stuff works. The rocket science isn't putting all those pieces together and overcoming all those challenges to get the care evidence-based to the right patient at the right time.
Just to jump in here, related to engagement and certainly identifying individuals who may benefit, we absolutely laser focused on that, but I think just to level set, as a carrier, we really have recognized that, our most important customer is our member, and we really understand that our system has really been not very friendly, if you will, to the individual who uses it. And so we really have been working to transform our relationship in terms of our health services to be very member-focused. We will join you, as opposed to you join us. Nobody, when they're depressed, ill, or injured, wants to know then that they have a very complicated maze that they have to go through in order to get help. That's not very compassionate and not very effective, as we know in terms of the data. A number of people who need services are not getting them, in part because they don't have the ability to actually get them, or their services are not there. So first of all, we cover these services. Our able to services are a part of our medical benefit. We're also launching in many of our segments in our national accounts, tele-video mental health visits, which we know for many individuals is a preference, not only if they live in a rural location, but even in an urban location. It's more convenient, they can schedule that at their own time, and we make sure that those are done with that quality in mind, that is evidence-based and properly credentialed practitioners delivering that care. In addition, our care management program has a very elaborate algorithm that not only helps to identify individuals who might benefit from an outreach, but also is proactive in identifying through claims data a forecasting of who's likely going to be needing services, so we can be more preventive, if you will, in the orientation, more proactive as opposed to the usual reactive way that healthcare is delivered. And we do that with a platform where we use a single clinician model, where there's a team of other clinicians that help support that individual, including a pharmacist in the case of somebody with dementia or somebody with multiple medical problems who's got mental health concerns. They may not understand what medications they need to be taken. There may be challenges with their medications. They may not have been having the proper monitoring related to those medications. So having the input of a pharmacist and a behavioral health specialist, special training for the nurses so that they can not only be effective in how they intervene and discuss issues with that member on the phone, but also have training to do proactive screening for depression, anxiety problems, and then help that individual navigate to the appropriate services so that they can get timely access to care.
I was going to cut. There's one word you use several times, which I absolutely love, and that's proactive. And we were chatting about this a little bit previously, right? As a doc, and you probably appreciate this too, Amy and Jay. Here's what I did in my practice. Okay, you come into my office, I tell you all these things that you should do, I send you on your way, and I ask you to come back in 1 year and report back on how successful you were. And, and sometimes you feel bad that you didn't, change your entire eating habits. You're exercising and running marathons now. You've fixed that relationship with your wife, which was the core of, your stress at home, right? There's all this space in the healthcare system that we're not sufficiently taking advantage of. How do we fill those gaps, right? And being proactive, I absolutely love that word. Being proactive about finding ways to reach out, whether it's with technology, with people, with care management, with all these tools. How do we fill those spaces so that at 1 year becomes 6 months, becomes 3, becomes maybe every minute of the day you're mapping something that feeds back, and we can be more proactive in making that outreach in a very timely way to get you that needed care.
The other thing I'll add to that is, you're mentioning your practice and how we how do we fill the spaces in between visits? I mean, even if you think about a normal care management model and that the disease management world has executed at Aetna and Cigna and other health plans, there's a monthly contact. Every 30 days you'll get contact. So in between physician visits, but even then, and I think about the model that we have where we're actually in the home for part of our business on a monthly basis. We've got great communication, great outcomes when we talk to people, when we're in the home that day or when we're on the phone. But what happens in between, right? And that's where technology play, like Vela and like Able2 can come in and actually help facilitate what happens. Because frankly, this what you are saying that I have on my team is, that's when all the drama happens, is in between these visits. Everything's fine when you show up or when you're on the phone, but the drama happens like the minute that you drive off or you hang up, and that's when we're trying to solve for is proactively identify for triggers that can prevent the drama from actually happening.
I like that.
Amy, you were mentioning a minute ago about you do video visits. What technologies are you using for that?
Right, so as a carrier, we're not actually providing the care. We include video, televideo, psychiatry visits, and mental health visits as part of our member benefits, and we have been partnering with 3 different televideo mental health companies that will be able to provide that within those states in which that is permissible.
Well, what I meant is this through a television or with a camera? Or?
You could do it on your smartphone as well.
And the reason I'm asking is, are you finding technology being a barrier for some of the people you're working with?
Right.
Because they may be tech adverse, so they can't figure any of this stuff out.
By the way, excellent question, Eric, and I think we should all just acknowledge we just had a bumper crop of baby boomers turning 70, okay, and I'm on sort of the tail end of that group, but I mean, this is a lot of people sort of entering into this phase where I think nearly 15% of individuals 70 and older are going to have dementia of some sort, not necessarily Alzheimer's, maybe other types as well, but we need to recognize that there's going to be certainly some generational differences in who's going to be more comfortable using some of these technologies, whether it be a smartphone or a tablet or televideo or telehealth services for that matter. We do offer Teledoc, for example, a service for sort of minor illnesses that people can call and have their illness or concern managed, but through the phone, if you will. But not everybody has a smartphone, and certainly depending on the generational issues, there's different preferences. What we've seen is many of our millennials, they much prefer that. This idea of driving somewhere and waiting in a waiting room for an hour to see somebody and then driving somewhere else doesn't make any sense at all when their problem could just be taken care of, and maybe even their medication dropped off to them. So there's really a big range of what's acceptable to people, but I think that we need to recognize that the pure demand, the burden of disease and the need to care for those issues is such that we can't continue to try to get more people through the treadmill on this current model. We have to look at the multimodal ways in which we can actually interface in providing care that's not only meaningful but timely, and quite frankly will help prevent any complications down the road, because we haven't waited until the 11th hour then to, say, go into the emergency department when the condition is much more advanced. So it's really about recognizing and embracing that there's a whole range of digital tools. There's telehealth that's developing quite a bit, as well as, of course, the traditional face-to-face kind of interactions.
And the reason I asked is because I know that even if a particular individual is able to use certain kind of technology, sometimes when they get older, they forget how to use it, or they can't hold up a tablet because their arms aren't strong enough any longer. So then you have to find alternative ways of communicating.
We used to be dogmatic, send everybody a video cam, help them set it up, and then we found bandwidth was a problem, and now we let the patient choose, and whatever works for them. If it's just the plain old telephone, I mean, we're fortunate in the delivery of mental health care, you can do that. Psychotherapy can be delivered by telephone with as good quality and as good outcomes as video or in person. So we let the patient choose, so that technology doesn't become a barrier to engaging and getting the care they need.
So with regard to the people who work with you with Able2, the therapists and so on, are they employees, or what sort of relationship do you have with them, and how do you vet them?
Yeah, it's a great question. So we have a network of about 300 or so providers who deliver our care all across the country. So they have to be licensed, as you know, the state regulatory requirements differ, and so we have 50 states worth of providers. They're licensed clinical social workers, some psychologists, some nurses, not yet psychiatrists, but one day in the future. Right now we work with our partners to enable delivery of psychiatry if needed. But they are not employees, they're contractors with us to date, but they're ours in the sense that we recruit them, we train them, and we supervise them in an ongoing way so that we know that the care being delivered is being delivered at high quality. And if it's not, we'll weed them out of our network.
So
that sounds awful, but we want to make sure the quality of the care is top notch.
So you're continually checking on them?
Yeah, the program is our program. So it's written as a structured 8-week protocol, which is sort of consistent with CBT, cognitive behavioral therapy, which can be somewhere between 8 and 16 weeks. So they're delivering our program, they're keeping their notes in our technology platform. All the data that's being collected from the patient is kept in our platform, so we can do structured data capture and patient-reported outcomes, and so we can track their outcomes for their patients and review their case notes, and we do case conferences. So there's a lot of layers in there of making sure the quality is top-notch.
And Amy, in terms of what Aetna's doing, is this a program you're rolling out with all of your
Right.
insured or?
Yes, so Able to
Pilot.
is one of other covered benefits, in the range of covered benefits that our members have access to should they want them. In some self-insured plans where a plan sponsor may specifically say, no, I don't want that, but no, it's considered a provider of care, of behavioral health care through this different medium.
I had to give Aetna a ton of credit. They took a chance, very innovative in partnering with us and with other companies with whom you partner. And in fact, Aetna has gone so far as to publish studies alongside us to show the value of the programs that we deliver together. And a couple years ago made us an opt-out, meaning let's bake it into our core behavioral health benefit. Make it available across the commercial book of business. And if, as you say, a couple of plan sponsors want to opt out because they have other resources, fine. But I mean, a very, very innovative approach to making this widely available.
And if you're an individual insured, if you buy your insurance privately through Aetna, is it available to those people as well?
That's a good question.
Right. I think plans may vary depending where they're sold. I don't know that it would be universally available, but certainly what we know is that the number of telemedicine visits have doubled in the last couple of years from what they were the year before. And so we know that this is a very briskly growing business, and it's only going to continue to expand. Even with some of the quality programs through Kaiser Permanente, a highly integrated system. Many more of their visits, in fact, Bernard Tyson, I believe, has said that the majority of the patient visits are going to be through telehealth in the future. So it is sort of a way of how we are going to be interacting with individuals, and to a certain extent, it makes sense. Not only is it cost effective in many cases, but it saves resources. If you don't have to drive across town and you're in a highly urban core, or you have to take time away from work. And I think for the area of telehealth related to behavioral health needs, individuals would prefer to have their visits after hours, not during work, in the privacy of their own space, wherever that may be. And it's much more likely to be timely, and I think that's going to be one of the areas that we need to be really aware of when there's limited access to behavioral health therapists, say, in the face-to-face setting.
And when you're talking about mental health, how would you define the sort of care that people are getting? Is it more counseling as opposed to psychological therapy, or? Because I know it's time limited, so it's not, you can't see somebody for 5 years.
Right. So I think the Able to program, and you could speak to this, with much more detail in terms of the length, but in terms of therapy visits, can go on for many, many months. Maybe it's a weekly visit, maybe it's a bi-weekly visit, what goes on for 6 months or what have you. But it's really with the cognitive behavioral therapy, with the idea that there may be some psychiatric visits if a psychiatrist needs to be involved. But I think we need to remember that the majority of antidepressants, for example, in this country, are not prescribed by psychiatrists. They're prescribed by your primary care doctors. And I know that Jay would say that's the truth now as well. So the doctor, the primary care doc, may be managing the medication side of it.
I think you can think of patients with mental health needs along a spectrum, and the treatment they get differs according to where they sit along that spectrum of the intensity of their disease condition. So on the far right of the x-axis, I'd put the severely mentally ill, what we tag as SMI. Those are folks with schizophrenia, bipolar disorder, high risk mental health conditions, which really often do require a psychiatrist, often do require in-person community-based resources for their care. Maybe augmented, and there's been plenty of studies showing that you can support and augment with digital tools or technologies, but those folks often need on-the-ground care. Then there's the other end of the spectrum, which I'd call the worried well. And I think apps and digital tools can be very useful. Often you don't need another human being. Some of that that pool of patients can be treated on their own. Then there's this core group in the middle, which often goes forgotten, and those are the folks with mild, moderate, bordering on severe mental health disorders, often comorbid with a medical condition. And for them, I think psychotherapy plus or minus a pharmacotherapy, an SSRI, an SNRI, can complement.
I won't quiz you, don't worry.
Yeah, I know. I'm like sitting next to the pharmacist going, I got to get it right. Or some combination. I mean, we're not therapy, I should say we're agnostic to the modality. In the end, whatever combination is right for the patient is what we're aiming for.
And those people in the middle you mentioned, because I think about dementia care patients, they're on the same spectrum. There's people who have huge behavioral issues that you need some support. The caregiver at home can just not do it alone. And then on the other side of the spectrum, you're just looking, people are just finding out about diagnosis or there's some symptoms and you're trying to figure it out. But there's the folks in the middle, which to your point earlier around the predictive nature and trying to identify who needs what modality and at what time. Because that's where we struggle on the Alzheimer's side as well is, you don't want people to move over too fast to the other side of the spectrum. And you want to make sure that you've got the right solution for them along the way, and being able to identify that through engagement is one of the keys.
Jay, Senior Link operates in several states.
Correct, yes.
Are you expanding? Why aren't you all over the place?
Well, yeah, we would love to be all over the place. Someone has to pay for the care, unfortunately, so that's the details. So our model right now is in primarily, and Medicaid is our primary customer, so fee-for-service Medicaid. We're also managed Medicaid, and when we're fee-for-service, we're working for states. So we're in 6 different states with our intensive care collaboration model, where we actually have our nurses and our social workers going into the home. The expansion that you talk about is, we mentioned evidence-based protocols. All of the work that we've done to show that 70% reduction in our small pilot on the Alzheimer's side, that's an evidence-based protocol. And the truth is there's only, I think, less than 2% of training modalities for caregivers on Alzheimer's are actually based on evidence. And so that's a gap in the market. So we've taken those protocols and we're trying to embed them within the technology solution Bella, so that way we can expand to more of a commercial market. And we are actually expanding in an independent physician association group in the Northeast later this summer, actually. So there'll be an announcement on some of the work that we're doing. And other payers, large health plans are also on our radar as well.
We've got a few minutes if anyone has a question or two.
Do you see out there?
Hi.
Okay. Are you getting any pushback from traditional physicians that don't want their patients doing virtual health or et cetera?
Well, thank you for that question. We actually had a small conversation before we had our panel, and one of the things that I commented about is that and I think this is changing with the younger physicians that are sort of being minted and coming in, but many of our older traditional physicians, I would say the majority, are less comfortable with these new technologies in terms of how healthcare is delivered. And I think part of it is they didn't really grow up with this technology age. They're not really using a lot of the digital. Some are, and I don't want to put that with a broad brush. There's a smaller proportion that are very excited about this. And I think that it is evolving. Part of it is that, and in fact, I would sort of be curious, Eric, is there anybody in the room that has used telehealth or had a telehealth visit by show of hands? I mean, it's a small number of hands that have come up. And I just had my first telehealth visit and it was great. And I thought, wow, this is really easy. I think that part of it is just, it's going to come in time. But it's a great question, and I suspect that as we see more and more academic medical centers recognizing the opportunity to train their clinicians who are going through their educational cycle around some of this, it will change over time, and more people who are demanding it. And unfortunately, we have a lot of our millennials saying, yes, this is how we're going to do it. They don't want to be bothered. In fact, they prefer this, many, over traditional visits.
I'll answer your question a slightly different way. We've never had a primary care doc come to us and tell us they were upset that we took care of their patient and addressed their mental health component of their care, right? So I think there is the piece about docs accepting technology and then accepting these other components of patients' health, whether it's caregiving, whether it's mental health, what have you, that, we've put all the burden on the shoulders of the primary care doc, fix everything. You know what, that's tough, and there's not enough hours in the day for the primary care doctors to do that. So great, if we can tackle this piece and that someone can tackle these pieces, that enables the doc to do what the doctor does best. And oftentimes that's not mental health, that's not caregiving. And that's what makes the system more efficient and effective overall. And I think we can get the docs to come around to that kind of appreciation.
I actually had an interesting, sorry, not to I'm going to be your fifth panelist, but I had a really, actually more of a question. I had a really interesting scenario in the sort of telehealth, telemedicine world. My insurance company signed on with a provider, and I was sick, had a really bad ear infection, and they took a phone call from me by the pool. They were by the pool with their children. And I found that I actually wrote to the CEO because I knew him. And I just said, I think you got to be concerned about this stuff, that you should be thinking about it, because she was seriously like, oh, my kids are swimming. I'm like, what the hey? So, and interestingly enough, it was not a misdiagnosis, but she did prescribe the wrong thing and blah, blah, blah. So I do think that, we talk about, all the awesomeness of it, and then yet we still have some stepping stones to manage quality. So I'm sure that they will.
I think you're right, Jill. I mean, you asked about our providers and what kind of quality and recruitment. I mean, that's part of the training, right?
Yeah.
There is a way to do this, and
there's a way to do it, yeah.
And privacy and security, and not poolside.
We're not really looking for an Uber driver to diagnose us, right?
Yeah,
like,
you need to be in an
somebody,
office setting,
yeah.
and if it's your home office, great, but it has to be a professional setting.
I think it's
so on
going to
and
be
so forth.
exciting, but I think there's going to be some quote-unquote malpractice situations that are going to bring us to the front. But anyway, Thank you so much. Great discussion.
Thank you.
Really fascinating. Thank you so much.